So actually, we're on YouTube. Search for
Empower Change. And it should say that it's live.
Tomatoes coming. Well, welcome everybody. There's some coffee and stuff out there on the side, so help yourselves. Speak my language.
Brother, how's it going? How you doing? Good to see you. How you been? Real good, real good. Busy with you. How's your knee? Clinic work. Yep.
You do a lot of work with
Mental health. Hello. Yes.
circle back around now. We can partner.
Yes.
Your what? We're trying to get somebody for video.
Oh yeah. I just watch out what the phone calls that you went to.
Yeah. I don't think it lets me like even look at it.
Okay.
Yeah, like I tried to even change like my brightness or something, and it didn't even let me do it. So, Oh, you know, I'm just gonna put on Do Not Disturb. No, it won't even let me. Oh yeah. Yeah.
This is me.
Yes, it should be last month.
Yeah, I mean, you could probably have.
Yes, I think we just met briefly.
So Mr. Mata
But so. No, yes, you're and I'm not about
I don't have a problem.
That's fine. You can pass it down this way. I was saving seats. That's my notebook now.
I grabbed a butter. Good morning, Mommy. Good morning, how are you? Good morning. I'm Brittany. Hi, Natalie. How are you? Hi, Anthony. How are you? Great, how are you? Yeah. I was like,
If you get a chance at like number 311, that's what I got from work.
María.
María, ¿cómo estás?
Hi, Brandy. I'm Denise. Hi. Yeah, we know that. I wondered if I was like, she's gonna be at these. George.
Good.
Have some here. And I'm like, I'll just wait because I only had one cup. Maybe one.
And then, yeah. Yes, definitely.
Good morning, everyone. I'm Sharon Butterworth, and I have the privilege of serving on the boards of both the Paso del Norte Health Foundation and the Meadows Mental Health Policy Institute. And I'd like to welcome you this morning to this Texas State Legislative briefing. It's being co-hosted by Meadows and by the Health Foundation. The Meadows Mental Health Policy Institute was created in 2013 by the Meadows Foundation to ensure that all Texans have access to mental health care wherever and whenever it's needed, and also to forever change the public perception and the negative bias toward mental health. So now, 5 years later, the Policy Institute is a catalyst for collaboration, change, and action. Our purpose today is to provide a preliminary analysis of mental health opportunities in this legislative session. And to begin, it is my pleasure to introduce Mr. Phil Ritter. Phil is the COO of the Meadows Mental Health Policy Institute. Prior to joining the Institute in 2014, Phil was the Executive Vice President for Government and Stakeholder Affairs at the Dallas-Fort Worth International Airport. And before that, he was Senior Vice President, Public Affairs with Texas Instruments. And he was also on the staff of the Texas Senate Jurisprudence Committee and was an attorney with Sun Exploration and Production Company. Bill has received his undergraduate and his JD degrees from the University of Maryland, and also a Master's of Public Affairs from the LBJ School at UT Austin. Bill resides in Dallas and is very active in his community. He currently serves as the board, the development board chair for the University of Texas at Dallas. So, Phil?
Thank you. Thanks, Sharon. I think we skipped ahead on our slides a little bit. Well, thank you. Good morning, everybody.
Good morning.
Welcome, and I want to thank Sharon and Enrique Mata for working to help set this up, and also our friends here at the Texas Tech Health Science Center for offering this wonderful facility to us. I'd like to introduce my colleague Cynthia Riley. Raise your hand here. Cynthia is our Vice President for Philanthropy and has joined us about 3 months ago and is working around the state to help develop support for our programs. And we got one other member of the MMHPI family here who is resident in El Paso, and that's Ruby Gonzalez. Ruby, stand up real quick. Ruby is a PhD candidate at UTEP, and she interned with us last summer at MMHPI and did some great work on employer payment systems and how we can get employers to be more involved in paying for mental health capacity in our state. And so it's great to see Ruby. And by the way, we have an internship program that right now we're beginning to take applications to work at MMHPI. You can work anywhere in the state in our summer internship program. So if any of you are interested in that, come and talk to me afterwards. But like Sharon mentioned, we were created about 5 years ago by the Meadows Foundation to really work statewide on behavioral health issues. And the Meadows Foundation had been doing grant making all over the state of Texas for 20 years, funding a clinic here and a program there, and they finally got frustrated with that approach because there was no improvement in population health outcomes. And so they decided to initiate a 2-year planning process to figure out what do we need to do to really transform the system. And what they decided was to take a policy-oriented, data-driven approach to doing that at both the state and the local level. And as part of the planning process that they put together, the vision is that all Texans have access to mental health care when and where they need it, and our role is really to provide independent, nonpartisan advice to the state and the executive branch, the judiciary, and the legislature but also to local communities and help local communities get oriented in planning for their system and collaborating around issues in their communities. And so that's what we've been about the past 5 years. Our sweet spot, if you will, is really looking at the interaction between state policy and what happens in Austin and how that affects the local communities. And some of you have been involved in this work for a long, long time and know this place, know this interface really, really well. But this is really an opportunity to really go in and change some things in state policy that has an impact on local communities. And that's going to be the theme of what Nelson's going to talk about. So as we look at the coming session of the next year, we've really got 3 things that we're focusing on. First off, to build on our accomplishments. And the legislature, the session that just began is the 3rd legislative session that we've had since the Institute was founded. And so there's going to be a whole lot that we're working to maintain in the system in terms of investments in capacity and state policy and not going backward on policies. And Nelson's going to talk about that. Second thing is there's going to be a huge focus this session on addressing the needs of children. And a lot of this is being driven by the response to Hurricane Harvey and also the school shootings, but recognizing as well that most mental illness manifests itself in adolescents and young adults, and if we can catch mental illness early before it progresses into more severe stages of the disease, we have an opportunity for better outcomes, and the legislature is understanding that and beginning to invest in early detection and prevention. And then finally, the last opportunity that we're really pushing is to start to think about mental illness as any other disease, and that we can eliminate. How can we eliminate depression in the state of Texas? How can we detect every episode of first episode psychosis in the state of Texas? We need to start thinking that way about mental illness because it is a treatable medical condition, and that's the way we need to approach it and fight it the way we do things like cancer. And there are big roles for academic medical research institutions like Tech, like UTEP in meeting that challenge. So with that, let me introduce my colleague, Nelson Jaron. And Nelson joined us about 3.5–4 years ago. And Nelson's an attorney. And he got his undergraduate degree at Texas A&M, and then he went to Notre Dame Law School. And he went to work in the Texas legislature for the Legislative Council, right? For Legislative Council, which basically drafts all the bills for the Texas legislature. And then from there, Nelson went to work for the chairman of the Senate Health and Human Services Committee, did that for several years, and was responsible for all healthcare policy for the Texas Senate at that staff level, a very key role. And then we hired him, and he's just done a great job for us in driving and advancing our legislative programs. And he's going to offer a presentation on what we expect to see happening in the coming session of the legislature. So with that, Nelson Jaron.
All right, thank you. Thanks, everybody. Is this mic working okay here? Good sound? All right, great. So Phil gave a good overview here. I'm going to present you with a lot of information this morning. We do want to leave time for questions, but feel free. I'm going to go through different segments of the presentation. So if there's questions at different segment, I'll stop if we want to have a discussion around that. There's a lot of things going on in behavioral health policy. These are the first 3 we're going to focus on. At the end of the presentation, I have 3 additional ones, and there's going to be other things that aren't in this presentation that are also big issue areas, so we can have a discussion about that at the end as well. I think we have ample time. It'll probably take me about 45 minutes to get through the presentation here. I've got about 30 slides. One of the big things you won't see on here is the 1115 waiver, for example, but we can talk about what we see as the path forwards for that. So we'll start with these 3 things, or these first items here that we see as big ticket items. So Phil mentioned that we want to build on our accomplishments, and what we mean by that is, as Phil noted, we've been around 3 legislative sessions, and it's not all because of us, for sure, but really the catalyst for the investment in the state's behavioral health system over the last 3 legislative sessions was the Sandy Hook school shooting tragedy that occurred in December of 2012. Since then, the legislature, it's been really a bipartisan focus to put additional dollars into behavioral health each session. This last legislative session, you'll see there was right at $750 million new dollars added to behavioral health. Since Sandy Hook, there's been about $1.7 billion added over the last 3 legislative sessions. So significant investments, and it's been a bipartisan issue with key champions, Democrats and Republicans alike, in both the House and Senate chambers. The total all funds budget is $7.6 billion for behavioral health. So that's our measuring stick this session, see how many billions there are, and we'll be able to see whether we have a gain or a loss. The way we know that is Senator Jane Nelson, the chair of Senate Finance, 2 sessions ago, she said, you know, you always see a bunch of articles out there in the news about behavioral health in Texas, we're 48th in spending. But when they're looking at that, the way our health agencies are organized, they're really only looking at the dollars that went out through one health agency, and particularly the dollars that went out to our local mental health authorities. They didn't look at Medicaid, they didn't look at Texas Department of Criminal Justice, DFPS, anything like that. So what Senator Nelson decided to do through the budget 2 sessions ago, she put a rider in the budget, and she said every agency that receives behavioral health funding, you have to come together and basically tell us how much you're receiving and what you're gonna do with that. So we now know that there's behavioral health spending across 18 different state agencies that totals $7.6 billion in this last budget. She also directed all those agencies to come together and put together a strategic plan for how those resources are gonna be spent over the next 5 years. And she wanted them to identify specific gaps to give the legislature direction about where we should put additional behavioral health investments. So if you haven't seen that, it's called the Statewide Behavioral Health Strategic Plan. It's a massive document. It's been out for about 2 years now, and they're going through an update right now. So I expect a new version of that plan to be out sometime in the next couple months. But that's really the guiding document for behavioral health spending in Texas. As far as strategies the legislature's done, they've done a lot of things like develop our crisis system. Our crisis system in Texas is actually a model for other states. After the movie theater shooting in Aurora, Colorado, they actually came to Texas and looked at our crisis system as a model. We've also done things like put dollars into wait lists each session, so people like Emergence and our other local mental health authorities across the state don't have wait lists for children's or adults' mental health services. That's been something critical to Senator Nelson each session to continue to put dollars in that. They've also made targeted investments for specific populations. So I'm going to talk about a few grant programs in a minute, and they pretty much all have the same theme to them, which is the state passes legislation that targets a specific population of mentally ill and puts dollars out there for that. So this started with the Healthy Community Collaboratives 2 sessions ago. They also passed Senate Bill 55, which was the Texas Veterans and Family Alliance. That's a program that provides funding for mental health services and treatment for veterans and their families. It's basically local communities, you come and tell us what your gaps are and draw down dollars from these different programs. So this last session, there was 2 additional grant programs that I'm going to visit with you about. So that's basically the gist of what we need on building our accomplishments. We want to hold the ground and basically build off the gains that we've made over the last 3 legislative sessions. So these are the grant programs. I'm not going to go very much into the details other than to say that the Senate Bill 292 was the new Senate grant program from last session. This one, just as the other ones in the past, have focused on targeted populations. Senate Bill 292 focuses on the intersection of criminal justice and mental illness. So how can we keep those that repeatedly cycle through our jails and ERs out of those environments and treat them in our communities beforehand? So it's essentially a statewide jail diversion program. It didn't have any strict requirements on it. It basically just said, local community, come and tell us how you want to do this, and we're going to provide the grant dollars for you to draw down in order to make that happen. So the key thing I want you to note on this slide from last session is that there was $12.5 million in the first fiscal year of last budget and $25 million in the second year. So that 12.5 was intended as ramp-up dollars. That was not full funding. This was intended as at least a $25 million a year program moving forward. The other grant program from last session was House Bill 13. If you heard about the Select Committee on Mental Health that Speaker Strauss created in December of 2016, it was chaired by Chairman Ford Price. They held 8 or 9 different hearings, took about 55 hours of testimony last interim. And the result of that was a big catalyst and momentum for behavioral health bills as well as funding last session. I'm trying to think if there was somebody from, I believe there was somebody from El Paso on that committee. Representative Moody, I'm sorry. Representative Moody's been a great advocate for these issues, and he was vice chair of the Select Committee on Mental Health last interim. So he's a great member to work with on these issues. So one of the key bills that came out of that Select Committee was House Bill 13. So this, where we had Senate Bill 292, was the Senate's version of the grant program they wanted to do. House Bill 13 was the House's version of what they wanted to do. And what Chairman Price and the other members of the House that passed this decided to do is not have a targeted population, whereas the previous grant programs were homeless, veterans, or criminal justice. He said, I want to create a grant program that allows local communities to address any type of gaps for adults or children's mental health services. So basically, local community, you come to us, tell us what your gaps are, go to the strategic plan, see how those gaps align with our statewide gaps, and draw down dollars through this program. So the key thing on this one is two things. One, $10 million was the first funding amount in this, the last budget cycle, first fiscal year, 20 million in the second one. So again, 10 million was intended as a ramp up year, 20 million at least or more was intended as full funding moving forward. And that'll be important in just a second here. The second key thing I want you to know is applicants for this grant program can be any nonprofit or governmental entity. So local mental health authorities can apply for this and they have their own separate round. But if you're a nonprofit or a governmental entity, if you're a health science center, if you're a school district, if you're a city, if you're a county, any type of nonprofit, you can apply for grant dollars through this program. So very critical for, I'm sure there's other nonprofits and people that represent governmental entities here, so I want you to be aware of that. I'm going to show you a couple maps here about the first couple rounds. So Senate Bill 292, they broke it into two rounds. They did one, they split out between our urban counties, and then they set aside money for our rural counties. Urban counties, there happens to be 20 defined urban counties in this state. The way this is defined in Senate Bill 292 is a county is urban if it has a population of 250,000 or more. So based on our 2010 census numbers, that's exactly 20 counties in this state. And of course, El Paso County is one of those counties. And so through Senate Bill 292, out of those top 20 counties, they were able to award 15 out of those top 20 counties with funds through Senate Bill 292. And Emergence Health Network in El Paso was one of the recipients of the Senate Bill 292 dollars. Andy Keller, our president and CEO, likes to say that he came from Eastern Washington, grew up in Spokane. He laughs at our definition of rural. He said, you know, Spokane, the whole area has 180,000 or so that would make that a rural area in Texas. But it is what it is. So the other 234 counties in the state are defined as our rural counties. So there was a separate round for them through Senate Bill 292. And the state ultimately ended up awarding grants to 10 awardees, but those awardees covered 31 different rural counties across the state. One county important here to note that didn't receive any funding through Senate Bill 292 is Hudspeth County next door here. So if there's a collaborative here that wants to get together and work on a Senate Bill 292 application for Hudspeth County for this upcoming biennium, that would be advantageous to get together and get the ground running. The projects that have been successful, they all had local collaborative partnerships where they already knew what type of gap they wanted to identify. So it wasn't that the request for the grant dollars came out and then they said, okay, what are we going to do or what do we want to apply for? They already had a plan and had a group of people working together to put that plan forward. House Bill 13 that I mentioned, you'll see that there's a lot more recipients on this. And the reason for that is not because there was more dollars, but because, again, that this one is eligible for nonprofits or any governmental entities. So there's a lot more opportunities to draw down dollars in this one. So the way I mentioned this earlier, the way they split this out, they did a round for local behavioral health authorities and, local mental health authorities and local behavioral health authorities. There was 25 different awardees that received funding through that. That's out of our 39 local mental health authorities across the state. And the second round of funding went out to nonprofits and other governmental entities, and there was 31 awardees that received funding through that. Key thing to note on this is that the round for local mental health authorities, Emergence did not receive dollars under that. So that's an opportunity to draw some additional dollars down, and that's no fault of Emergence. There was a lot of demand for these dollars. I remember it was 10 million and 20 million last time. So this was an oversubscribed program and there wasn't enough money to go around. But Emergence, they got money for Senate Bill 292. They did not get dollars for House Bill 13. However, the round that was open to nonprofits and other government entities, there were two providers here that did receive funding for El Paso County. That's Project Vita Health Center received funding through House Bill 13, as well as the National Alliance of Mental Illness, or NAMI, received funding to provide services in El Paso County as well as multiple other counties. So the key thing to know is that through Senate Bill 292 and House Bill 13, new grant programs that we're hoping to continue going and continue to grow, that there's additional dollars that are being drawn right down in your community here. That's not just usual dollars that go out through the budget. One other program that I wanted to briefly identify for you, Senate Bill 55 that I mentioned, that was the model for many of these programs that created the Texas Veterans and Family Alliance. Remember, this is the program that focuses on mental health services for veterans and their families. That one last session received $20 million, and there was 2 programs from El Paso that received funding. Emergence Health Network received dollars through that, as well as Family Endeavors received dollars to serve El Paso County and multiple additional counties. One key note on this, they had $20 million, they sent it out, they've awarded about $10 million so far, but we're currently in fiscal year 2019 up until August 31st of this year. So there's still $10 million for this program that's yet to be sent out. I expect it to come out sometime during this legislative session, so sometime in the next couple months. So there'll be another opportunity for El Paso or Hudspeth County to apply and draw down more dollars to treat veterans and their families through this program. So I set that up to say that what are the grant funding opportunities for this session? I mentioned the ramp up here, so Senate Bill 292, ideally keeping that at least $25 million. Remember, that was the full funding level, keeping that at least $25 million a year going forward, so $50 million over the biennium. There's a little segue to do here. Harris County, the model for Senate Bill 292, Harris County previous had a jail diversion pilot project that was the model for Senate Bill 292, and they received $5 million under that. They still receive that $5 million, but they don't apply through the other dollars that are available. So this is really a $60 million program because you have 25 and 25 plus 5 and 5 for Harris County, if that makes sense. So keeping that at those levels for the upcoming biennium. House Bill 15, keeping that, again, it was 10 million ramp up, 20 million full year, keeping that at least at 20 million per year. If you're gonna advocate down at the Capitol, you could definitely advocate for more dollars to go into House Bill 13 because both of those rounds for local mental health authorities and for nonprofits and governmental entities were oversubscribed. I heard somebody tell me that there was $100 million in ask for one of those rounds. And there was essentially 15 million available for each, 15 and 15. So you can include that in your advocacy efforts. And then Senate Bill 55, $20 million to keep that going, keep the veterans program going at least $20 million. I will say the good news is that the House and Senate, their base budgets came out last week. The veterans money is already in both of those budgets at 20 million. The Senate has the dollars in, I believe they're actually in both of them. The Senate one actually has them carved out right now with a rider. It's really hard to figure out what's going on in the budget by just looking at the total numbers. I think these are fully funded in both budgets right now, but it doesn't hurt to advocate for those levels or additional levels and keep that momentum going because ultimately those dollars have to stay in the budget from now until the end of May when the budget is passed. Anything on the grant funding opportunities? That was a lot of information, I know. Any questions or anything on that? Great. This next part, I'm not going to spend too much time on. It's our state hospital systems, but I do want you to be aware of this because there's been a lot of dollars put in this, and it's going to be a big ticket item for this legislative session, so I want you to be aware. But we have 10 state hospitals. They're located at 11 different campuses. That's why there's 11 and not 10 up there. The North Texas campus has 2 campuses, Vernon and Wichita Falls. El Paso is lucky to be the most recent member of the state hospital system, built in 1996. But you can see that other members of the state hospital system, such as Austin State Hospital, Terrell State Hospital, were built in the 1800s. Austin State Hospital is our oldest, built in 1861. If that year is familiar to any of you, you'll remember from US history class that was the start of the Civil War. So that's our model for care right now, is aged back 150 plus years. And just to get in the weeds a little bit, there was a report a few years back where they took a look at all of our state hospitals. The ones on the left were the ones that were too far gone and needed to be bulldozed. The ones on the right are the ones that were in good shape but could use some deferred maintenance, some renovations and repairs. So that's the state of our hospital system. This is a little map that shows our catchment areas. El Paso, you can see that you have a broad catchment area over the Big Bend area in West Texas. You can see that the catchment areas that, the reason is that we're in an 1800 model for state hospitals. By and large, our state hospitals are out in rural communities where people with mental illness were sent to live their lives for a long period of time. Besides El Paso, Austin, and San Antonio being in our big cities, our other state hospitals are out, for lack of a better term, in the middle of nowhere. So it's not an ideal recovery system for people to be closer, to their family, their support network, closer to transition back in their community for care. As far as law enforcement and even on the civil commitment process, doing transport to state hospitals, it's a nightmare. You can see people down in the valley, they have to drive to San Antonio. Harris County is currently zoned for Russ State Hospital, so that's a 3-hour trip north to Russ State Hospital for Harris County. So it's not ideal. So we've been working with the state to transform our state hospital system, doing that closer to where people live, and ideally aligning our state hospitals in partnership with our medical schools. Harris County, they have a really good model. It's not on the map because it's not technically a state hospital, but what they have is the Harris County Psychiatric Center, which is jointly owned by Harris County and the state, but it's run by UT Health, the medical school in Houston. It's owned and operated them. And their length of stay and their treatment outcomes are significantly better than at our state hospitals. The last data I saw, the average stay at a state hospital is 107 days or 112, somewhere around there. The average length of stay at Harris County Psychiatric Center is about 40 days. So when you're paying $700 a day and you're trying to turn beds around because we have a significant wait list for people to get in state hospital beds, any additional day matters. When you have a gap of 60-day difference, that's hugely significant. So a couple of medical schools have stepped up to play a role in hospital system redesign, and the legislature last session took the first step in that. They allocated $300 million out of our rainy day fund for the first phase, of which was intended as a 3-phase process to redesign and modernize our state hospitals. So I just want to briefly give you an idea of what's been going on there. The biggest thing has been that Austin State Hospital and San Antonio State Hospital, remember those were 2 on the left on the bulldoze list, both received about $15 million in planning dollars to plan for a new, modernly designed state hospital. The Harris County Center I mentioned earlier, they got $125 million to expand and build a bigger facility that's going to have about 240 beds in Harris County. The benefit of that is that that will allow us to redesign these catchment areas here, whereas people from Galveston currently go to Austin and people from Houston currently go to Russ. That allows the state to redesign that because that'll be state beds in Harris County. The other key things is maximum security, which does affect El Paso. People that are incompetent to stand trial or that need a state hospital that have been charged with certain offenses, they're known as maximum security commitments, and they need a maximum security unit. Well, the only maximum security unit in our state is the North Texas Vernon State Hospital. So if you have somebody in El Paso that's charged with one of these offenses and is incompetent to stand trial, you're on a wait list with about 440 other people right now to get into Vernon. There's a few beds in Russ, there's about 60 there, but the bulk of ours are all up in Vernon State Hospital. So the legislature recognized that we had a maximum security issue. They invested construction dollars in Russ State Hospital to add 60 maximum security beds there. They also added 70 max security beds at Kerrville, and those will be available for the entire state, including El Paso, for people that are on the max security wait list. So that was really the first focus, was let's add some maximum security capacity. Let's build a new building in Harris County to allow us to redesign our catchment areas, and let's get Austin and San Antonio in the planning process. Phase 2 transformation opportunities, the Senate budget, their supplemental budget, they just allocated $300 million to fund phase 2 of the state hospital redesign. Those dollars aren't in the House budget yet, but the House hasn't filed a supplemental bill. Supplemental bills, for those of you that don't know, we have a regular budget, and then we always fall short and come back and pass a supplemental budget to fund what we didn't fund before. So there's always 2 budgets. There's the main budget and supplemental. So the supplemental does provide another $300 million. But as I noted, Austin and San Antonio both have been planning hospitals, so they're going to be competing for those $300 million or asking for more because the cost estimates for Austin State Hospital is about $293 million. San Antonio is $323. So it's kind of which one is going to be funded. I don't see the legislature putting $600 million in that. But there's also a talk of a potential new hospital in Dallas, as well as the Texas Panhandle, Lubbock, Amarillo region as well. So potential planning dollars for those. So those are some things to watch, but I would expect at least $300 million to be funded to fund phase 2 in this upcoming budget cycle. Anything on state hospitals before I move to what we see as the biggest opportunity this session? All right. Children is, as Phil mentioned, is where we see the biggest traction. We like to use the cancer analogy at the Meadows Institute, and for very long, we talked about building up our crisis system. Really, the state is focused on building up our crisis system and focusing on adults. It's been really difficult to get children involved in the conversation, and what we say with our cancer analogy is we've really been treating mental illness at stage 4. We'll have another slide in just a minute, but 50% of mental illness shows symptoms by age 14. And those people that have schizophrenia or bipolar disorder and are homeless at this point or cycling through our jails and ERs, those are people that had symptoms early in their life. We didn't intervene early with the right care and treatment. They've essentially fallen through the cracks and that's how they are where they are today. The only way we get ahead of that curve is to intervene aggressively and treat mental health issues in adolescents and young adults just like we do anything else. In cancer, if you found breast cancer and it was stage 1, they wouldn't say, well, just come back and see me when it's stage 4. We don't have any treatment for you. So that's our aspiration, is to find and treat everybody that has mental illness, when they show symptoms, not when it gets to stage 4. So the legislature has really been focused on adults, but because of Harvey and then of course Santa Fe, we think there's a really good opportunity for children this session. I do want to be clear that we at the Institute do not believe that the Santa Fe shooter did that because he was mentally ill, and we don't want to create stigma around mental illness. People that have mental illness, by and large, they're more likely to be victims of violence than they are to commit violence. There's a specific segment, and that's people that have untreated psychosis that has a higher rate of violence and homicide that I'll get into in a minute. But that's really violence and homicide, like familial homicide or suicide. It's not a person that's going to necessarily go grab a gun and shoot up a school. So we're very clear that you can go and do everything you want in the world for children's mental health. You're not going to find the needle in a haystack that's going to go out and because of a personality disorder or because of just pure evilness is going to go shoot a school. But our message has been, you can't find the needle in the haystack unless you treat all of the hay. So we need to treat all the children that need intervention. On this, I want to show you a couple things. Mainly, this is up here to show you that the Meadows Mental Health Policy Institute likes numbers and data, and so we don't expect you to see all these, but the key thing is when we're talking about children and young adults between 6 and 17, we have about 5 million children and adolescents at that age in Texas out of our roughly 28 million people. And the other key number to focus on here is 20,000. That's our school to prison pipeline, as we call it. Those are kids that because of behavioral issues or mental illness that's occurring, a lot of times are treated more in the juvenile justice setting or alternative setting. They might go to alternative school. They fall into their juvenile justice pipeline and eventually end in our criminal justice pipeline. So that'll make more sense in just a minute here. I mentioned this earlier, but 50% of mental illness begins by age 14. 75% of cases have presented by young adulthood. And the key here the message we've been trying to send to the legislature is we need early detection and intervention with those kids, but we also have to have the appropriate treatment. So when you hear things like mental health first aid or trauma-informed care, those are good things, but that's on early detection. We can't just do training programs to make people more aware of mental illness. We have to have the appropriate treatment and the places to send those kids to once we identify them. We also have to be careful that we don't overly identify kids. We don't want to just medicate kids. We want to include people that are counselors or social workers, other people. We don't just want to send everybody to a doctor and have them go on a medication regimen, especially if that's not the necessary treatment for that child. So we like to define the ideal mental health system for children with 3 key components. And these come from, as Phil mentioned, we do a lot of local systems work throughout the state. We've done a number of assessments, and these are assessments that are by and large funded by philanthropic organizations or health foundations. But these 3 key components come from a children's assessment that we did in Harris County. So we were funded by a funder to look at Harris County, the current availability of services, and what an ideal mental health system would be for Harris County. What should they aspire to be? So it's 3 key components. The first one is helping schools identify needs and link to help. We call that a school liaison function. I'll get into more detail on that in just a minute. The second is helping pediatric primary care providers find and treat mental illness early. I'll get into that in a minute. I just want to lay these three out for you. And finally, the number three is making the intensive treatment available to those with the most severe needs, and that's the 20,000 school to prison pipeline I mentioned a minute ago. So the first one here, the school liaison function. There's been a lot of discussion, after Santa Fe, Governor Abbott came out, he's hosted a series of roundtables where he had different themes for different days. One day was school hardening, one day was all about mental health and hearing from teachers. And there's been a lot of different discussions from different associations, which counselors, for example, counselors I think ideally would like to have a counselor in every school, or you hear the same thing, but from a school psychologist. Our point of view is that that's not feasible in a state with 1,200 school districts, and you really need to look at the local needs of that school. What is the school? What works for them? Senator Whitmire, who's the chair of criminal justice and has been in the Senate longer than any member, he's the dean of the Senate. He represents Harris County ISD, and he said, I don't have enough teachers in my school. We don't have nurses. I can't see a school counselor ever being in some of my schools. And we agree with that. So we think that there needs be a pot of dollars for local communities, local schools to decide what their school liaison function is. That can be a number of things. You could use those dollars to put school counselors in your school, with the caveat they need to have dedicated time for mental illness or to work with kids. Not necessarily mental illness, but social anxiety, anything like that. A lot of the testimony we heard following Santa Fe was that counselors were overburdened with advising students on their careers, or proctoring tests, or monitoring lunchrooms. So they have to have protected time to focus on their core duties. It can also be school-based clinics. There's a great clinic in Austin ISD. They have a partnership with Vita Clinic, where they actually have clinics on campus where kids can just walk through a door that doesn't look like any other door and go in there and visit with a counselor. That's not going to be feasible in every school, but that's another thing that works for a different communities and schools and other programs. But ideally, again, it's a pot of dollars that allow people to work in the school district, whatever model works for them, provide an initial assessment, provide some counseling if they can, but also be able to be a link to care. Even if you have a counselor or somebody or a program like this on campus, we shouldn't expect that that person is going to solve every issue. They can do what they can, but they also have to be able to connect that person to more appropriate care if there's a need for follow-up. So the funding opportunities for this, the legislature, what came out of the governor's roundtables was an initiative at the Texas Education Agency called the Safe and Healthy Schools Initiative. And it's grounded in 4 pillars. Those pillars are mental health supports, positive school culture, that's going to be things like training for PBIS and social emotional learning, facility safety, which is in the school hardening arena, and then emergency response coordination. So, law enforcement, first responders, alerts and drills, how do we respond if there's an active shooting scenario? And so we're advocating for the Safe and Healthy Schools Initiative, or advising that the Safe and Healthy Schools Initiative should be fully funded. That $52.5 million, that doesn't go very far between 1,200 school districts. So that's something, another message you could take to the Capitol is this really needs to be a more robust number. So that's one. And number 2 is to have as much of those dollars as possible go towards the mental health supports and positive school culture components of these 4 pillars. And so what's happened, I mentioned the budgets just came out. The House-based budget fully funded the Safe and Healthy Schools Initiative request. They actually put $54.5 million in there. 37 million of those went out to the mental health and public school culture components. So that's the starting place in the House right now. The Senate put $100 million towards school hardening. They haven't funded this yet, but I think by the end of session, there'll be some sort of agreement or it will be funded. So again, $54.5 million, 37 million of which goes to mental health and positive school culture. The way those are currently envisioned is school districts would be applying and be able to draw down those grant dollars, again, to use in the school liaison function, as I showed before. There's a lot of other more detailed components to that. I'm happy to follow up with you, which each component does after if you'd like. I just want you to know that there's right now a pot of dollars for school districts to pull down. I also put House Bill 13 in here to mention the grant program from up front. Remember, governmental entities can't apply, so school districts can't apply. Texas Tech Health Science Center in Lubbock, they have a program called the Twitter program that received some press after Santa Fe improved the governor's roundtables. They were able to pull down HB 13 dollars to expand this to, I believe, 7 additional school districts in the Panhandle. So I just want you to know, if you advocate for additional dollars in HB 13, you can talk about how that addresses gaps in children's mental health services, and there's an opportunity for school districts and nonprofits to pull down dollars through that to address children. Another bill I want to mention is Senate Bill 63. This bill creates the Texas Mental Health Care Consortium. This was filed by Senator Jane Nelson, who's long been a champion on behavioral health causes. On November 12th, that was the first day that any members of the legislature can file legislation. This bill now has 31 joint authors and co-authors in the Senate. There are 31 members in the Senate, so everybody in the Senate is signed on to this bill, including local champion Jose Rodriguez. So 31 members on it. What this does, to give you a little bit of background, we have 12 state-funded medical schools across the state. One, of course, is the campus we're on here, the Texas Tech Health Science Center at El Paso. 3 years ago, Dr. Lakey, he was the former commissioner of the Department of State Health Services, decided to create a Chairs of Psychiatry group, which pulled the Department Chairs of Psychiatry from all the 12 medical schools across the state to have them work together on how they could leverage medical schools and state institutions to help address behavioral health and mental health challenges across the state. They've done a number of key things. They put together a research framework. I'll get into the research component in just a minute, but just to let you know, we did an inventory for them. The state, between all our medical schools right now, we pulled down about 1.5% of the federal NIH dollars, and Texas is 9% of the population. So we're pulling down just 20% of our share right now. So we wanted to leverage that expertise, see how they could work together to draw down more dollars for research. The states also put them to work. I mentioned our state hospitals being in the middle of nowhere. Vernon, that handles our maximum security unit. The other key issue with hospitals being in the middle of nowhere is they can't get their workforce. Psychiatrists, nurses in particular, is a challenge. So the Vernon Hospital that handles maximum security, they couldn't get enough psychiatrists to treat. They brought that issue to the Chairs of Psychiatry, and now UT Health in Houston is providing telepsychiatry to Vernon to fill in those gaps in services. So those are the kind of things the chairs have been working on over the last 3 years. And basically Senate Bill 63 takes the chairs group and puts them together to focus on 3 key things. And the first is some children's mental health initiatives. This bill, Senate Bill 63, was funded in the Senate-based budget with $100 million fully funded to go across multiple different pieces. But the first key thing I want to mention here is that there's Senate Bill 63 allows the use of telemedicine and telehealth programs to provide services to children, namely intervening in schools. So particularly out in rural areas, there could be some, or even in El Paso here. I mean, there's after Harvey happened, UTMB and Galveston, for example, they're providing a lot of telemedicine and telehealth to the Harvey affected regions up and down the Gulf Coast. So it's a way to leverage our medical schools and have them provide their expertise, their telemedicine and telehealth networks to provide children's mental health services. So that's the first key component on this bill. I'm going to mention it in a few different ways coming up. I'm rolling into the second piece of the Ideal Children's Mental Health Network now. This is talking about leveraging our pediatric primary care providers. The reason that this is important is that 75% of children with mental health issues receive care in a primary care setting. And so what we're trying to do is enable those pediatric and primary care docs to treat as many of those kids that present in those settings as possible and reserve our limited child and adolescent psychiatrists for more severe conditions. Just like you would do with if a kid has a sprain, but if you took your child into a pediatric office now and there was a sprain there, they might do an x-ray and put it in a splint. They're not going to say, okay, we're not going to do anything. We're just going to automatically refer you to an orthopedic surgeon for treatment. So we're trying to get to the same point. The way that we believe that you do this is through a program called the Child Psychiatry Access Program. This is a program that's run in about 31 other states right now. The longest running program is the Massachusetts Child Psychiatry Access Program, which is known as MCPAC. And basically what this is a statewide network of consultation hubs that are run through medical schools. Massachusetts is able to do this through 3 medical schools, and it's child psychiatrists, it's counselors, care coordinators, but basically they're an on-call 7 days a week, roughly 16 hours a day, phone a friend for pediatric and primary care docs. Any pediatrician or primary care doc can call them free of charge for consultation about a child that has a mild or moderate condition that they're receiving treatment for. So what that it does 2 things. It enables them to treat those kids in their setting and then only refer the most severe cases. It also works like continuing education because each call, the pediatrician is becoming more and more comfortable handling mental health conditions in their office setting. And then again, that doesn't go back and mean all medication, because there are behavioral health professionals like counselors on those teams as well. We also do things like put together education worksheets about how to work with kids that have mental illness. They also, in some communities, help connect people to care and do referrals. But the number one issue is the consultation for the pediatricians. And so potentially the medical school here in El Paso is in a position to draw down some dollars and provide this service to the El Paso and greater region. And that's through the Senate Bill 63 that is also funded in there. So the CPAP opportunity, I mentioned about 31 states have this right now, but the prototypes for this, there's a few areas in Texas that currently do this. The main area is Children's Health in Dallas has a small program that does this. And then secondly, we were able to work with some healthcare providers in Harris County to ramp up some philanthropy to get this going. And this was a key for the Harvey response. Soon after Harvey hit, at first everybody was worried about their house getting flooded, but shortly after that it was about, well, my kid is starting to have anxiety or depression. We started getting calls from schools. We worked with Governor Abbott and the TEA, Texas Education Agency, and he created a school task force on Harvey response, essentially. And it was basically to work with TEA, local mental health authorities, other behavioral health providers, to provide a link to care for all those kids that were affected by Harvey and starting to show signs of anxiety and from the trauma they experienced. So philanthropy in the Harris County area, they stepped up to the plate and they funded a CPAP model for 2 years through Baylor College of Medicine, UT Health Houston, Texas Children's, and Harris Health. But philanthropy alone cannot sustain this, and that was just for Harris County. Of course, there was a lot more trauma down in Aransas County and down by Corpus and Hebron and the Orange and Beaumont area. So we ideally need this CPAP model across the state. And that's what Senate Bill 63 does, has filed. It funds a network of child psychiatry access hubs across the state of Texas to provide coverage, ultimately broken down in regions for the pediatricians and primary care docs that are seeing kids. One note, if you're talking about that at the Capitol, Senator Nelson didn't like the abbreviation CPAP, so she refers to it as CPAN. She thought CPAP sounded too much like a breathing device. It's called CPAP in every other state, but it'll be known as CPAP, the Child Psychiatry Access Network in the state of Texas. And because Senator Nelson is the chairwoman of Senate Finance and controls the budget in the Senate, she can call it anything she wants. So. The third leg of the stool, making intensive treatment available. I mentioned the 20,000, the school to prison pipeline. We're coming back to that now. From our local assistance assessments that we've done across the state, we estimate the state's treating we have the capacity currently to serve about 5% of our highest level need kids. So 1 in 20 kids across the state, roughly we have the capacity for that. The key thing is not all of those 20,000, they don't all have the same behavioral health issues or diagnosis, so they don't all need the same treatment. We have to ramp up various different types of treatment. But the thing that we see the opportunity is around first episode psychosis, ramping up treatment to intervene with psychosis, and I'll give you a few reasons for that in a moment. The next logical step we think behind that is evidence-based treatments like multisystemic therapy and some other things that are done in other states. We think there's roughly 7,000 to 9,000 kids that fall in that spectrum. These are more kids that are going to have more discipline issues in school and end up more in the juvenile justice setting, acting out through that. But MST is kind of the best practice evidence-based intervention for that population. But the traction around first episode psychosis has been really strong at the Capitol, so I want to highlight a few things on this population. So first is that there's about 900 new cases of first episode psychosis each year. That's in child and adolescents. Psychosis generally occurs between 14 and 35. So we're saying that roughly 900 new cases between 14 and 18. We didn't go out and count those 900 kids, but we have pretty good epidemiological estimates and data that we apply based on race and poverty and other factors in the state. So that number might be off plus or minus 100, but we think it's pretty accurate. And those are new cases that are going to happen each year. Psychosis, for those of you that aren't clinicians and are lawyers or others just like me, psychosis is generally will present as symptoms of people believing things that are not true, so having false beliefs, seeing something that's not there, or having hallucinations or like voices whispering in their ear or something of those nature. I mentioned how mentally ill people, by and large, are more likely to be victims of violence. This is the one population where that doesn't necessarily hold true. The only thing where you see a statistically significant change, and that's with those with untreated psychosis are 15 times more likely to commit homicide than those that have treated psychosis. Again, that's not grabbing a gun and shooting up a school. It can be more things like familial homicide or even suicide. You'll see that below that, they have 24 times the elevated risk of suicide compared to their peers, people with untreated psychosis. And today, treatment is delayed on average for 5 years after onset. First episode psychosis means I've had my first episode, so my first break where I heard voices or saw things. We generally, right now, we don't intervene until 5 years after that happens. The issue with schizophrenia is that it can cause brain damage left untreated long-term, to the point where it can be irreversible if you have this happen. And many of our people that we talk about that are in stage 4, those are people that had their first episode of psychosis in their early teens, early adulthood, and didn't receive the proper treatment, and that's why they are where they are today. The best treatment model for treating psychosis is coordinated specialty care, also known as CSC, but this is a team-based approach. And this isn't rocket science, but they did a big study out this in New York. It was called the RAISE program. And after doing the research, looking at the data, the takeaway was that if we want to better treat psychosis, we need to intervene and treat it early when it first presents. So not rocket sciences, but the best treatment is to intervene within the first 12 to 18 months after that first psychotic break. Texas currently has 12 coordinated specialty care teams across the state. Each one has a capacity to serve roughly 30 people at a time. And those are not just children, young adolescents, young adults. That would be capacity all the way from 15 to age 35. So right now we can treat roughly 360 people in the entire state. We have roughly 900 new cases that are just 18 and under. So we're only serving a fraction of the need right now. But those 12 coordinated specialty care teams, they're located at 10 community centers across the state. One of those programs is right here in El Paso at Emergence Health Center. So that's great that you do have a program here. Just to show you how far we've come on psychosis in 4 years. In 2014, we first got funding. All of this funding thus far has come through federal dollars. It comes through the Federal Mental Health Block Grant, and the state uses a set aside from that to start up these teams. So 4 years ago in 2010, we had 2 teams in the state. We had one in Houston and one in Dallas, both serving 30 people. So we had the capacity to serve 60 people, and that was located only in our 2 biggest metropolitan areas. So we now have, they added a second team in Houston, a second team in Dallas, and they ramped up at 8 different sites. So we're headed in the right direction. That was in 2016, they ramped up these additional sites. And next slide, we are ramping up even more because if anybody follows the federal budget, March of last year, there was a giant appropriations bill that passed through Congress. There was a Christmas tree where everybody got a little bit of something they wanted, and there was a lot of dollars in it. Well, the federal government got a lot of dollars for the mental health block grant, so the state was able to draw down $3.7 million additional dollars for that set aside. And through that, we're currently in the process is expanding to 12 new sites through those $3.7 million. So we're now going to have teams located at 22 community centers across our state sometimes in 2019. So we've gone from 2014 having 2 teams, one in Houston, one in Dallas, to now having 22 teams across the state. Again, remember they can serve roughly 30 people at a time. So that puts up as a capacity right at 660 people. It's not enough, but we're definitely headed in the right direction. There's significant traction around this. The other key thing is that the Health and Human Services Commission, because to date, all of this funding for first episode psychosis teams has come from federal dollars. For the first time ever, the Health and Human Services Commission this session has asked for the state to put in state dollars to ramp up additional capacity for first episode psychosis. So what this is, it's known as an exceptional item. The way the budget works is all the state agencies come to the state with a legislative appropriations request, which is basically, please fund this in our base budget, and then exceptional items are their wish list. Please, legislature, fund this, this, and this item. So coordinated specialty care expansion is item number 19 and HHSC budget request if you're visiting on this at the Capitol. And it would seek to provide $7.9 million in both fiscal years next year. That would allow the state to take coordinated specialty care completely statewide. So we would have it at all 39 community centers, as well as there's discussions about having this ramped up at our medical schools and other community providers. It doesn't have to be a $0 or a $7.9 million decision. Each new team costs roughly $400,000. That's one additional team that can treat up to 30 people over a year. So it's a very important, exceptional item to help build on that intensive services, that third leg of the Children's Mental Health School. Any questions on children's? All right. Number 3 is fight mental illness like we fight cancer. I'm going to briefly hit on this. This is on research. So ultimately, Phil did a good layout of this. Andy, our CEO, likes to talk about the MD Anderson Cancer Center. The MD Anderson Cancer Center in Houston, it is a state institution, but it's also the leader in the treatment of cancer. Andy was in San Francisco Airport last year sometime, and there was an advertisement for the MD Anderson Cancer Center in San Francisco, and his wheels got to turning. He said, you know, I'm here with Stanford, with UC Berkeley, and yet they're advertising MD Anderson Cancer Center in Houston right in the middle of this, you know, awesome healthcare center in San Francisco. And our goal long-term is to have something like that in Texas. How do we get an MD Anderson for the brain, for brain health? How do we make Texas the beacon of hope for people, just like people come from all across the world to get cancer treatment in Houston? How do we get people to come from all across the world to get their brain health treatment in Texas? Right now, you'll hear a lot of the times the biggest provider of mental health services in our state is the Harris County Jail. People aren't going to fly from the Middle East or Europe to go to the Harris County Jail because the services are so awesome there. So in the state hospital discussion, pairing some of those with medical schools like the Austin State Hospital, they're working with Dell Medical School. Dell wants to have their chair of psychiatry, their department of psychiatry on campus there and do research and things there. So there's opportunities to do that and create truly a beacon, but research is another way to do that by drawing in federal dollars. That's really how we got to where we are in cancer. You have a number of dollars that are pulled into your research institutions. We're able to hire more faculty, do more research, and Phil mentioned earlier research. We don't want research done in ivory towers just for research's sake when there's papers written. We wanted to translate to community health benefits. So what are things that are actually going to help us intervene earlier or treat, you know, provide better treatment for mental health? I brought this up to somebody in Dallas and they said, we already know what to do for mental health. We just don't have the dollars to do that. I don't necessarily think that's the case because UT Southwestern, for example, they're looking at biomarkers for children in the womb to try to detect if they're going to be at a heightened risk of schizophrenia. So I think we're really just scratching the surface with what we can do. So in the context of the chairs of psychiatry, I mentioned earlier, but we prepared the Texas Mental Health Research Framework. All the chairs from the 12 medical schools got together, and their idea was let's pick some ideas where we can work collaboratively on key mental health and substance use disorder research priorities. They identified these 5 focus areas at the bottom: depression, first episode psychosis, substance use disorder, bipolar and schizophrenia, and community system research. That's number 5, is that translational research that actually affects community and population health. They've coalesced around those areas. And then Senate Bill 63, coming back for the 3rd time. Part of that $100 million funding will go to research in Senate Bill 63. So Senate Bill 63 on the research component, it specifically directs the consortium of those medical schools to develop and implement a mental health research plan, create an inventory of current projects, which we've already done through the chairs of psychiatry, and then leverage our state-funded medical schools to draw down additional funding and use effective and targeted research. They're already working on a project right now that they started last year. UT Southwestern took the lead. They're doing a project through Dallas Community College, screening and doing early intervention for depression and early psychosis. UT Southwestern is the lead, but there's other medical schools that are partnering with them on that. And the UT system, Dr. Ray Greenberg, they put in $500,000 to help them pilot that. That was the pilot, kind of the framework for what the chairs will hopefully do in the future through these research dollars. So that's the last piece on research. Slide this is my last slide. I'm gonna hit on 4, 5, and 6, then we can have a discussion about 1115 waiver or any other thing that you would like to visit about, because we've still got plenty of time here. So these are the other remaining opportunities that we see to advance Texas behavioral health policy in the 86th legislative session. Number 4 is building on the momentum created by the Texas Judicial Council's Mental Health Committee. In the May of 2016, the Texas Judicial Council, which is the policy-making body for the state judiciary, they decided to create a mental health committee, which is really important because a lot of the issues for jails, competency restorations in our state hospitals, those are really judiciary driven. You have somebody with mental illness that comes before their courtroom, they commit them to a state hospital, that individual goes back to a jail, and they're waiting in the jail for a long period of time for a state hospital. The other big issue with our state hospital beds is currently we have about 2,500 beds in our state hospital. 34% of those people in the state hospitals have been there over a year, 365 days or longer. You can find out if somebody's going to restore to competency or get better within 30 to 60 days of initiating treatment. So we're essentially housing or taking up space for 34% of our beds right now. It's $700 a day because we don't have anywhere else to send these people. These are people that might have IDD or traumatic brain injury. They're never going to be not need support, but they're never going to get healed in a state hospital system. So the judiciary last system, they had a giant bill, it's about a 50-page bill, Senate Bill 1326, that tweaked with competency restoration. It allowed jail-based competency restoration. It put more focus on outpatient competency restoration. There was funding through 292 that allowed communities to do that. It also looked at assessment and how we screen people when they're first brought into the criminal justice system to identify if they have behavioral health issues. But ultimately, the Judicial Council and the state judiciary, there's more to be done, more leadership that can help us with our state hospital issues and our waitlist issues, and so there's some bills that are starting to be filed that are coming out of that. The second big issue is building on our behavioral health workforce emergency. We don't just have a shortage of psychiatrists, we have a shortage of all behavioral health professionals. One of the biggest things, or opportunities I see for this next legislative session on this is the behavioral health sunset legislative session on this is the behavioral health sunset legislation. If anybody's familiar with the Sunset Committee or what it does here, we have an agency called the Sunset Advisory Commission. And roughly every 10 to 12 years, the state agency goes through what is called sunset review. So it's a top to bottom review of that agency to find out what tweaks we can make to make them work more efficiently and effectively. Last legislative session, all the boards that license mental health professionals were up for sunset review. So you've got, at the Health and Human Services Commission, you've got LMFTs, so licensed marriage and family therapists, you've got LPCs, licensed professional counselors, and LCSWs, licensed social workers. All three of those are at HHSC right now. HHSC is the biggest state agency in the country. They have 55,000 employees at HHSC. So the licensing is horrid over there right now because they don't get any attention. It takes forever for new graduates to get their license. People moving out of state, it takes forever for them to get a license. We're talking months and months on end. And so what the recommendation was to pull those three behavioral professionals and join them with the psychologists. The psychologists currently have their own standalone board, but they wanted to pull all four of those professionals together and create a Texas Behavioral Health Executive Council. So that would be one council that would oversee licensing for all four of those professions. That doesn't mean that if you're a social worker, you're going to get policed by psychologists if you have a rule violation. You still are equally represented. They just want to be pulled out of HHSC so they can have a greater focus on getting licensing out the door. There's a lot of other good sunset recommendations, things like fast track licensure for out-of-state people that are moving here, revisiting if you need to do some of the professions require like an in-state like board exam, like in person, you have to come and do an interview. Doing away with some of those archaic things or really high requirements for training that don't really align with other states. So there was this big sunset bill last session. The psychologists like things the way they are because they have their own board. The psychologists killed that bill last session in the House Calendars Committee. It didn't pass. So those three professions, the other three professions got stuck in HHSC for another 2 years, and all the good recommendations that would have streamlined licensing and helped us out all died with that bill. So it's back again this time. It's been unanimously adopted through the Sunset Commission, and it's moving through the process again. And so when that bill gets filed, it's really important that it makes it all the way through this time and that we don't lose all the good work in there. So that's a key thing for all of our professions generally. Beyond that, Senate Bill 63, I want to mention, there's a model that MetroCare, which is the local behavioral health authority in Dallas, and UT Southwestern have used for years, where they take some of their psychiatric residents and they rotate them through their local community provider. So it's essentially 2 residence rotation spots where they can rotate multiple residents. 2 residence rotation spots where they can rotate multiple residents. But what that allows them to do is they're augmenting the delivery of public mental health services because they're serving in a community center. And they're also gaining exposure and gaining more interest in that environment. We don't need to just graduate a bunch of new psychiatrists and have them go out into the suburbs and not take insurance or just take cash payments. We need more in the public mental health system. And they've had a really good track record of keeping the people, those residents, in public mental health systems. A lot of them have gone to work on in other local mental health authorities across the state. So Senate Bill 63 provides funding in that for roughly 10 of those slots across the state. So Texas Tech Health Science Center in El Paso could partner with Immersions here to rotate residents through and augment the delivery of public mental health services. The other key thing, the House budgets for House Bill 1 and Senate Bill 1, this was it was unexpected, but pleasantly received, I should say, is the Higher Education Coordinating Board that oversees residency programs. They had an exceptional item for right under $61 million to expand our residency spots. The state's always been trying to get a 1.1 to 1 ratio. And what that means is for too long, we were an exporter of doctors. So the state would graduate doctors and they would go to do a residency in other states because we never even had a 1-to-1 ratio. So we didn't have enough residency spots just for the number of doctors we graduated each year. So actually our Lieutenant Governor and Senator Nelson in particular have been big champions of this ever since the Lieutenant Governor was elected, about putting enough money in our GME, our residency training, so we're not just using taxpayer dollars to educate doctors that go out of state. Because by and large, when you train for do your residency, doctors generally stay within an 80-mile radius of where they do the residency training. So if we're just training doctors here and they're going to New Mexico or California, we've lost them and we need them here because we have a shortage in not just psychiatry, but family medicine and many other professions. So the state has been trying to get to this 1.1 to 1 ratio, which means that we would have enough slots for 1.1 medical school graduates. So enough for every graduate in Texas and enough to get some out-of-state docs that other taxpayers paid for to come here and train in Texas. And so that was going to require $61 million in this budget, and usually exceptional items are figured out later on in the legislative process. Both the House and Senate realized that this is enough of a big deal that both those budgets now contain that $61 million. So I think that'll stay in there at this point, but that's a huge opportunity for the Health Science Center in El Paso to draw down not just additional psychiatric residency slots, but more residency slots in general. And finally, there's going to be traction around opioids and substance use. Just like I mentioned, that Speaker Strauss created the House Select Committee on Mental Health. This interim, before Speaker Strauss left, he created the House Select Committee on Opioids and Substance Use Disorders. It was kind of the next iteration of the House Select Committee on Mental Health. Chairman Ford Price was again the chair, and Representative Moody was again the vice chair of that committee. They did a similar thing where they had multiple hearings, took 40 to 50 hours of testimony. They just published a 117-page report in December with their findings. So there is going to be some traction coming out of that. The biggest thing is we have a lot of federal dollars coming from opioids. They're not being designated as a national emergency. And so there's been a lot of federal dollars funding down. Actually, the state is having problems getting all those dollars out right now because they have to use contracts. And if you followed any of the news around HHSC and contracting going around in Austin, there's been a little highlight on that issue, I should say. And so it's taking longer to get the contracts out, and so they have these millions of dollars coming in. It's very difficult to get the dollars out in the community. But beyond that, we don't want to lose sight of other substance use disorders that are also critical to the community, so alcohol abuse or methamphetamine. So the state, HHSC again, they have an exceptional item to expand substance use beyond just opioids in there. And I do think there's going to be some legislation that will be filed, especially out of the select committee members from the House. So if you have any ideas on substance use, I would recommend visiting with Chairman Moody because he's on that committee, he's intimately involved with these issues, and I'm sure he'd want to be a champion for El Paso down at the Capitol next session. So with that, that is the end of my presentation. We can talk about the 1115 waiver or anything else I didn't cover, or we'll leave it up to the will of the body. So questions from anybody? Yeah.
Just in general, we talked I'd like to hear more if there's anything on outpatient services for the general population. Is that something that we would submit under grant applications, or is there specifically anything within legislation addressing that?
So would that be provided through a community center or?
Yes.
Okay, so those are the specific line items in the budget. So when I mentioned the wait list dollars earlier, there's a $59 million exceptional item request to fully fund the wait list and any cost growth at the local mental health authorities for services. There's also different line items in the budget. So you have a line item for adult mental health services. You have one for children's mental health services. You have one for crisis services. You have one for contracted beds. All of those are different strategies that you would need to advocate for. The waitlist dollars, I believe those are already taken care of in the budget. So it's 59 million total. I'm not sure what emergencies breakdown is for that. So that puts you at a base level, and then you can always advocate within those strategies for additional dollars. If it's somebody you can also augment through your grant programs, there's nothing to prevent you from drawing down additional through that, as well as other providers in the community. As long as they're a nonprofit or government entity, they could use those grant programs to try to leverage some dollars for additional outpatient services. Anyone else?
Nelson,
Yes.
you've done this briefing now in Lubbock and in Fort Worth and in San Antonio. Could you give the group a little bit of a flavor about how other communities are organizing for the session and things that, some other parts of the state are focusing on that, may be illustrative of things that could happen here?
Sure. I mean, I think that the key thing, like Phil said, we've been doing these policy briefings in a few different communities, and we're just presenting these as opportunities. I know that everybody's going to have their own legislative opportunities and their own, wish list they want to advocate for. These are just paths that we as an institute see they're going to advance the behavioral health system. And because I'm in Austin and I'm intimately involved, these are the things where I see most traction. So I'm just putting that out there. That shouldn't keep you from doing your own efforts or any specific projects that you have. But ultimately what I see is we're doing this first for education purposes to let people know kind of where some traction is, but two, to let people in different communities coalesce around priorities and work around different things that they can do in unison at the Capitol. Because the more uniform voices we have from these different communities like a Fort Worth or a Lubbock or El Paso, if everybody's coming down there and saying we need more dollars that are going to be in schools, for example, that can be flexible dollars that school districts can draw down to hire counselors or whatever works from those needs, that really helps the process, because you have not just Jose Rodriguez saying it, you have Charles Perry from Lubbock saying it, or you have Beverly Powell from Fort Worth. So creating a unified message around a couple of key things and let everybody know kind of the inside baseball. The other key thing is a lot of these communities, some of them are ahead of others. Fort Worth that has a really good group there, but as far as these grant funding opportunities, the state has put a really big premium on collaboration. So they don't want to see, even if you're a nonprofit or a government entity, they don't want you to just apply as a standalone nonprofit. They want really a lead agency that's signed on with other people. That's how you rise above. And so these groups that we've been talking to in different communities, they've been a catalyst for those conversations about who can be the leader in our community and what do we want to put forward as a community as our proposal. What do we want to go after? So I would say that that's the few key things around it. And thinking that just like the select committee report from the mental health select committee, it was a one-time report. I think it's a once-in-a-generation opportunity. But think about this in long-term local systems transformation. Like that select committee report, that's a blueprint for the next decade. The state behavioral health strategic plan is a blueprint for the next 5 fiscal years. So this isn't, a lot of people said about Senate Bill 63, well, it doesn't do anything for our lower level professionals. It doesn't like augment our social workers or this and that on it. We're not gonna solve everything in one legislative session. We're building on our opportunities. Envision where you see yourself. What do you come back and ask for in the 87th legislative session? So how are the things that you're building on in the 86th, how are they getting you towards that goal there? So we're taking this at the long game. We're not gonna build Rome overnight. We're not gonna transform our behavioral health system overnight. Sharon?
Nelson, talk about the 1115 waiver
Sure.
and what the future is.
Is anybody terrified about the 1115 waiver down the way? No hands? Really, other people are like, I get through it and the first thing, all the hands go up and like, what are you hearing about the 1115 waiver? They're terrified. So 1115 waiver originally was a $29 billion waiver. It was split up into 2 funding pools, uncompensated care pool, which mostly goes to hospitals, and a disparate pool, which is basically projects at the local level. Basically, it was designed to provide these projects, and you're supposed to use them to collect data and prove what works. But it was a huge multi-billion-dollar boost into Texas. A lot of those projects, district projects, are behavioral health centered, and it's a waiver. It's a Medicaid waiver that was negotiated with the federal government. So we were able to get an extension negotiated, but the district dollars, they're on par to go completely away in 2022. So I think right now we're receiving about, it's starting to taper down, but roughly $500 million a year in district dollars are going out to behavioral health. So you can imagine if those dollars completely go away, we have a $500 million vacuum that comes out. Those aren't dollars that are directed through the state. They all go out through RHPs or regional health partnerships all across the state, our anchor entities. If those vacuum out of there, we're going to take a huge step backwards, because if you think we have a wait list and a scarcity of services now, just wait until $500 million vacuums out of the equation. So the path forward for that, there's a big group down at the Capitol, which is led by John Pitts. John Pitts, his brother was a former chairman of appropriation, Jim Pitts, in the House, who's a longtime House member. But John Pitts is a lobbyist on the outside. He's been funded to put a big group together with the Texas Medical Association, Texas Hospital Association, Texas Council of Community Centers, and a bunch of other key providers to put together a district or a 1115 waiver transition plan. And so there is a plan to do this. You don't really need legislation. It really needs just direction to the agency through the budget. It's ultimately about the state of Texas negotiating with the federal CMS to get this approved. But what they're proposing to do is to take the dollars that are currently available and provide private healthcare plans for everybody that's up to 100% of the poverty level. Because a lot of those dollars in treatment that's going to people in their 1115 waiver right now are people that aren't eligible in Medicaid in Texas as adults, because we have very stringent requirements on adults for Medicaid, and they don't make enough to qualify for private plans through the Affordable Care Act, or they don't have insurance through their employer. So by and large, it's people that are very impoverished, and the state is basically using the 1115 waiver just to provide services right now. So the idea is to negotiate a new waiver that would take those dollars and provide a private health plan for people up to 100% of poverty level, and it would be under a 90-10 match. So the 10% match would come from some sort of local transfers, which I think is going to be leveraged from hospital dollars, is how they envision it right now. So there is a plan that the big entities around there have coalesced on. The good thing is when of course our political system has been very anti-Obamacare and anti-Washington DC, so there wasn't really a hope of anything working out before. The extension that we got was after President Trump took over, when there was better feelings between Texas and CMS and a new director of CMS, so they were able to get the extension. But again, those district dollars are tapering down and go to zero in September 2022. So we have to renegotiate the waiver. The other good thing is Chris Traylor, who was the former executive commissioner of the Health and Human Services Commission. He is now at CMS, and he is the head of Medicaid up there. So we have a phone a friend up in DC. So it's not something that's being talked about very much at the Capitol, because it's politically dicey, because it can be viewed as Medicaid expansion because it's using those dollars, but it's done under the 1115 waiver, and they're proposing to do it through private health plans. So I think the best thing to do on that is to build up more concern about the urgency of this, not really say that there's a solution out there and you can do that if you want, but really hearing from communities about this 1115 waiver is going away. We're going to lose hundreds of $millions of funding. What are you guys going to do about it? So there's not that sense of alarm that you would think of something like this. Generally, you would think that with something of this caliber, there would be newspapers all across the state that would be writing stories, hospitals would be writing in. So I think there's some confidence this is going to get taken care of, but it doesn't really have the attention and the debate at the Capitol that I think it deserves. Enrique?
Nelson, along those lines, when you're talking about the 1115 waiver, with CMS, is there any new movement on like expanding or broadening reimbursement models for certain kinds of mental health treatments? Maybe we're learning more about child behavioral health, and in particular, that's where I'm looking, but ways that makes it more enticing for primary care physicians to have that real-time behavioral health component inside of their, and that's a broad statement, I know. But
Sure. Yeah, I'm not, I spend all my time focused on Texas, and if a big thing pops at the federal level, I'm not sure what CMS is doing down in the weeds on that. Rates, of course, are always an issue. If you look at our budget and the amount of money that we spend on our healthcare portion, which is Article 2, and our public education component, which is Article 3, that basically eats up our entire budget. So the legislature, the way that they're able to control that, since Medicaid is an entitlement, they always hammer the rates or try to cut costs in Medicaid to scale that number back. I'm not sure what it is this session, but I know 2 sessions ago, our budget was over 200, it was a little over 200 billion, and about 75 billion of that was Medicaid. So it's basically 1/3 of our budget. And so that's really been the tactic, is to, if it's an entitlement and you have everybody coming in, the only thing you can do is either cut your rates or try to narrow networks so people can't access the services. So rates are definitely a critical component of that. I don't see too much traction just because of the amount of dollars that have to go into Medicaid. I mentioned the supplemental budget. The supplemental budget, we have a shortfall of $2.1 billion from last budget cycle on Medicaid right now, just Medicaid dollars that we didn't fully fund last time. So it's a huge item. So just to making our cost and population growth full is going to cost us that much. So I know all the people that work for the medical professionals, TMA and others, they're always advocating for increased Medicaid rates, but because of how big of a portion it has to our budget now, I just haven't seen much traction around that, which is unfortunate because we know that would help the access issues and help strengthen networks, but that doesn't mean that you shouldn't keep hammering that message down to the Capitol.
Yeah, another part of that payment systems and capacity building issue, relates to the private sector and private employers. And, the Institute's involved with several statewide business organizations in educating the business community on the value of early detection and screening and integrated care, and making sure those payment systems are in place. And so if there's an opportunity to engage the employer community out here in El Paso on that and share that information, we'd be delighted to work with you on that.
And follow up on that, last session, one of the big bills, one of the great bills that came out of the work of the select committee was House Bill 10, which was a parity bill. For those of you that don't know much about parity, it's basically our insurance plans. It's basically saying that you have to, if you provide mental health or substance use benefits, you have to provide those on par with medical and surgical physical health benefits. So a copayment or a copayment can't be higher for a doctor visit for a mental health issue as opposed to a physical health issue. There's also things that are that they tried to mask, like they'll try to constrict networks, and that's not parity either. That's called non-quantitative or qualitative parity. So not looking at numbers, but just looking, I say it doesn't pass the smell test. So they say that the network is saturated with psychologists, but you can't get an appointment for 3 months, which isn't the same deal if you need to go see an allergist. So parity, that bill passed last session, and it allows the Texas Department of Insurance that oversees private plans and Health and Human Services that oversees Medicaid to have full parity enforcement authority. There's now a parity website where people can file complaints, which is key to ratcheting up this issue. So the extent that you can, if you work for a big organization, make people aware that there's a complaint process and they're trying to do something and actually get data on this now. Because before, when we heard about this in the select committee, TDI came forward and they said that they received either, it was 4 or 5 parity complaints in the previous year and 0 the year before that. We knew that there's no way that's accurate, but we know that most people, parity is a complicated thing, so they probably just called up TDI and said, I'm complaining because I can't get a doctor visit for my kid. Well, that's not parity, that's like access. That is parity, that's non-quantitative parity, that's hidden parity issue. But really, TDI probably reported that as an access issue. And so to really shine a light on parity, but to Phil's point, private plans, when we looked at that data, private plans represent, I think it was 41% of the insurance in the market, and parity at the state level is preempted. So you can't the state cannot regulate private business funded plans or known as ERISA funded plans. So that impetus to do that accounts for 41% of our health plans, has to come from the private market. And what we have done is try to educate businesses, particularly around depression and the workforce, how that affects not only their employee, but their employee's family for productivity loss, and how that hits their pocketbook, and help to advise and educate businesses on how to better design their plans to provide more rest, mental health, and substance use benefits. So to the extent that we can get any traction on that, with any private employers out here, we'd be happy to assist with that as well.
That's really big.
Yeah, parity, that's a huge bill. And without the select committee, that wouldn't have passed last time. If you would have told me that the health plans wouldn't have killed that bill, but they would actually come in and supported the bill, I would have said you're crazy, that was never gonna pass, but that's exactly what happened. It's because Chairman Price, Vice Chair Moody and others, they had another parity bill that the health plans liked even less. And it was like, pick your poison, they're like, we will take House Bill 10, so that's what happened.
So just to clarify that, when you say private health plans, I mean like University of Texas may have a private health plan, right?
Mm-hmm.
So it's not just like ADP or one of these corporations.
Right, so that, the private health plan here, I don't think that's an ERISA plan. Those are regulated by the state as a state plan. So you have ERS for state employees, TRS for teachers. You have UT system plans, and A&M has system plans. Those, I'm not sure if those are ERISA self-funded plans or not, because those are regulated by the state. So I think that you would be able to do parity violations against the state on those. But I think they do a pretty good job with their benefits and designing their benefits. But
Yeah, these employers, the traditional public or private employers is, okay, there's mental illness and substance use, I'm carving that out, I sign up a separate vendor to run an EAP and I've solved the problem.
Right.
And their employees don't access those programs, but, and, you know, they've got this compliance issue with parity, but the big thing is, you know, the main healthcare conditions that employers pay for, it's diabetes, heart disease, chronic pain, and cancer. And if you've got somebody with untreated depression, you're gonna pay, as an employer, 3 times more for primary care for that person with untreated depression than an employee who doesn't have it. And so there's a huge economic rationale for employers to rethink how they purchase healthcare, and that's what we're trying to drive home in the state of Texas with these employer groups.
And the integrated care component that Phil mentioned is really critical as well, especially in our Medicaid plans, because we've moved to a managed care system where it's supposed to provide integrated care. Managed care is that the state, for Medicaid enrollees, they pay a health plan, a set amount per member per month, and they're supposed to handle the benefits for that individual. Many of the Medicaid plans, what they do is they handle the physical health benefits, but they contract out to a BHO or behavioral health organization for their medical benefits, or for their mental health and substance use benefits. So if you're doing a truly managed care holistic approach to an individual, you have 2 different cost streams you're looking at when you should be looking at one cost stream, the whole wellness of the person. And there was a bill last session that would require for people that have integrated clinics to have just one contract with a Medicaid managed care organization, but that didn't get anywhere. Because the idea right now is if you have an integrated clinic, you have to have one contract with a managed care company for the physical health component and one for the mental health and substance use component, which if we're really trying to reach the goals of Medicaid managed care as envisioned, that makes completely no sense. We're 3 minutes over. Want to be respectful of your time. Any other questions or anything? I hope that was helpful to y'all and helps you with your efforts at the Capitol. And if you'd like to talk to me afterwards or you need any follow-up information, I believe we'll send out the slides at least to everybody that's here today. Feel free to follow up. We're funded almost exclusive of life philanthropy, and that capacity allows us to do things like this and provide assistance to you and other communities across the state. So thank you very much for your time this morning. I hope it was beneficial to you.